There is a particular moment that many people describe when asked about when they first noticed something had changed in their legs. It is rarely dramatic. It is usually something small and almost embarrassing in its ordinariness. Standing up from a low chair and needing to push off with both hands where once you would have simply risen. Climbing a flight of stairs and feeling a burn in the thighs that did not used to be there. Getting out of the car after a long drive and feeling, just for a moment, that the legs need to remember what they are supposed to do before they can be trusted with full weight. These moments accumulate quietly, one small adjustment at a time, until one day a person realizes that their legs, which carried them through decades of life without much conscious thought, have become something that requires attention, requires care, and sometimes requires real concern. This experience, so common as to be almost universal among people over 60, deserves to be understood properly because the weakness that develops in the legs after 60 is neither mysterious nor inevitable in the way that many people assume, and understanding what is actually happening opens up genuine possibilities for doing something about it. The leg weakness that develops with age has a specific biological name and a specific biological cause, and understanding this cause is the necessary first step toward understanding what can be done about it. The condition is called sarcopenia, derived from Greek words meaning poverty of flesh, and it refers to the progressive loss of muscle mass and muscle function that occurs with aging. This is not a vague or impressionistic description of getting older. It is a specific and measurable physiological process that researchers have studied extensively, and the numbers involved are significant enough to deserve genuine attention. After the age of 30, the average person loses approximately 3 to 8% of their muscle mass per decade, and this rate of loss accelerates significantly after the age of 60, sometimes to a degree that some research suggests can mean losing 15% or more of remaining muscle mass per decade in people who are not actively working to counteract the process. The legs, containing some of the largest muscle groups in the body and bearing the constant demand of supporting body weight and enabling movement, are often where this loss becomes most noticeably significant in terms of its effects on daily function. Understanding why this happens requires looking at several overlapping biological processes that converge to produce the muscle loss that characterizes sarcopenia. The first is a decline in the body's ability to synthesize new muscle protein in response to the stimuli that would normally trigger that synthesis, a phenomenon researchers call anabolic resistance. In a younger body, eating protein and engaging in physical activity trigger a relatively efficient process of building and repairing muscle tissue. In an older body, this same combination of protein intake and physical activity produces a smaller and less efficient muscle-building response, meaning that older adults need more of both protein intake and physical stimulus to achieve the same muscle-building effect that a younger person would achieve more easily. This is not a permanent or insurmountable barrier, but it does mean that maintaining muscle mass after 60 requires more deliberate effort than it did at 30, when muscle could often be maintained with relatively casual attention to diet and activity. The second contributing process is a decline in the function and the number of motor neurons, the nerve cells that connect the brain and spinal cord to the muscles and that are responsible for triggering muscle contraction. As people age, some motor neurons die, and the muscle fibers that were connected to those neurons either die along with them or get reconnected to neighboring motor neurons in a process that, while it allows some continued function, ultimately results in larger but fewer motor units, a change that is associated with reduced fine motor control and reduced overall muscle power even in muscles that retain reasonable mass. This neurological dimension of sarcopenia is part of why some older adults experience not just weakness, but also a sense that their legs are less responsive, less precisely controllable than they used to be. The third contributing factor is hormonal change, particularly the decline in growth hormone, testosterone, and in women estrogen, all of which play roles in supporting muscle protein synthesis and muscle maintenance. The hormonal shifts that occur with aging, while a normal part of the life course rather than a disease process in themselves, do remove some of the biological support that muscle maintenance previously had, contributing to the overall trajectory of muscle loss if not actively counteracted through other means. The fourth and in some ways most important factor, because it is the one most directly within an individual's control, is simply reduced physical activity. As legs become weaker and movement becomes somewhat more effortful, many people unconsciously reduce their activity level to avoid the discomfort or the difficulty of movement that has become harder than it once was. This creates a vicious cycle that researchers have documented extensively. Reduced activity accelerates muscle loss, which makes movement even harder, which leads to further reduced activity, which accelerates muscle loss further. This cycle, once established, can progress relatively quickly, and breaking it is one of the most important interventions available for anyone experiencing leg weakness after 60. Beyond the general process of sarcopenia, there are several other specific factors that can contribute to or accelerate leg weakness in older adults, and understanding these is important both for accurate self-assessment and for knowing when professional medical evaluation is warranted rather than simply assuming that all leg weakness is the normal and expected consequence of aging. Peripheral artery disease, a condition in which narrowed arteries reduce blood flow to the legs, can cause weakness, cramping, and pain, particularly during walking, a symptom pattern called claudication that improves with rest. This condition is more common in people with diabetes, smoking history, or cardiovascular disease, and it requires specific medical evaluation and treatment because it reflects broader cardiovascular health concerns beyond just the legs themselves. Peripheral neuropathy, nerve damage that commonly affects the legs and feet, and that is particularly common in people with diabetes, but that can have other causes as well, can produce weakness along with numbness, tingling, and altered sensation. This condition also requires medical evaluation because the underlying causes, when identified and addressed, can sometimes be managed in ways that prevent further progression of the nerve damage. Spinal stenosis, a narrowing of the spinal canal that can compress nerves serving the legs, is a common condition in older adults that can cause weakness, particularly weakness that worsens with walking and improves with sitting or leaning forward, a pattern that is distinct from the muscle-based weakness of sarcopenia and that may require specific orthopedic or neurological evaluation and treatment. And certain medications, including some used to manage cholesterol, can in some cases contribute to muscle weakness as a side effect, which is worth discussing with a healthcare provider if weakness develops or worsens after starting a new medication. Given this range of potential contributing factors, anyone experiencing significant or rapidly progressing leg weakness, particularly if accompanied by pain, numbness, or other neurological symptoms, should seek medical evaluation to rule out or address these more specific conditions before assuming that the weakness is simply the general and expected consequence of sarcopenia. But for the large majority of older adults experiencing the gradual generalized leg weakness that reflects ordinary age-related muscle loss, the encouraging news, and this deserves to be stated with real clarity and real confidence because the research supporting it is robust and consistent, is that this kind of weakness is substantially reversible through appropriate intervention, even in people who have been experiencing it for years, and even in people of quite advanced age. The single most effective intervention for reversing age-related leg weakness, supported by an enormous body of research spanning decades and including studies on participants well into their 90s, is progressive resistance training, exercise that involves working the muscles against increasing resistance over time in a way that provides the stimulus the body needs to rebuild and strengthen muscle tissue despite the anabolic resistance that aging produces. The research findings on this topic are genuinely remarkable and deserve to be communicated clearly because many older adults have absorbed a cultural message that suggests aging bodies should be protected from exertion rather than challenged by it, a message that the research on resistance training directly contradicts. Studies looking at resistance training in older adults, including studies of nursing home residents in their 80s and 90s, have consistently found significant improvements in muscle strength, often in the range of 30 to 100% improvement in measured strength over relatively short training periods of 8 to 12 weeks. These are not small or marginal improvements. They represent substantial functional changes that translate directly into improved ability to perform the activities of daily living that depend on leg strength, including rising from chairs, climbing stairs, walking distances, and maintaining balance in ways that reduce fall risk. The body's capacity to respond to resistance training with genuine strength gains does not disappear with age. It is attenuated somewhat, requiring more consistent and more carefully structured training to achieve the same relative gains that a younger person might achieve more quickly, but the fundamental capacity remains intact throughout the lifespan. For someone beginning to address leg weakness through resistance training, starting appropriately is important both for safety and for building the kind of sustainable habit that produces results over time. The squat, in some modified or supported form, is one of the most valuable exercises available because it directly trains the muscle groups most important for the functional activities that leg weakness affects, including rising from seated positions and climbing stairs. For someone with significant weakness or balance concerns, this might begin as a sit-to-stand exercise using a sturdy chair, simply practicing the motion of standing up from the chair and sitting back down with control, using the arms for assistance as needed initially, and gradually reducing that assistance as strength improves. As strength and confidence build, this can progress to bodyweight squats performed with a chair behind for safety, and eventually to squats with added resistance through bands, weights, or other forms of progressive load. Leg presses, whether performed on gym equipment or through resistance band variations that can be done at home, provide another valuable exercise that trains the major muscle groups of the legs in a controlled and supported way that may feel more accessible than standing exercises for people with significant balance concerns. Calf raises, which can be performed holding onto a counter or sturdy support for balance, target the muscles of the lower leg that are important for walking stability and that are often particularly affected by age-related weakness. Step-ups, performed using a stable step or the bottom step of a staircase, directly train the specific movement pattern involved in climbing stairs, one of the functional activities that leg weakness most commonly affects. The principle of progressive overload, gradually increasing the resistance or the difficulty of these exercises over time as strength improves, is essential for continued improvement rather than simply plateauing at an initial level of capability. This does not mean rushing toward heavy weights or advanced exercise variations. It means a careful, gradual progression that respects the body's adaptation timeline while consistently providing enough challenge to continue stimulating improvement. Working with a physical therapist or a qualified trainer who has experience with older adults, at least initially, can be enormously valuable for ensuring that exercises are performed with correct form and appropriate progression, particularly for people who are starting from a point of significant weakness or who have other health conditions that need to be considered in exercise programming. Frequency matters considerably for resistance training effectiveness, and the research generally supports training the major muscle groups of the legs at least 2 to 3 times per week, with rest days between sessions targeting the same muscle groups to allow for the recovery and adaptation process that produces strength gains. This frequency is achievable for most people without requiring excessive time investment, with sessions of 20 to 30 minutes several times a week being sufficient to produce meaningful results when performed consistently over time. Alongside resistance training, several other forms of physical activity provide complementary benefits for addressing leg weakness and the broader functional concerns that accompany it. Walking, while not providing the same intensity of muscle-building stimulus as resistance training, supports cardiovascular health, maintains the neurological patterns involved in walking itself, and provides a foundation of general activity that supports overall function. Water-based exercise, including water walking and aquatic resistance exercises, offers a particularly valuable option for people with significant joint pain or balance concerns, because the buoyancy of water reduces the impact stress on joints while still providing meaningful resistance for muscle strengthening, and the support that water provides can allow people to attempt movements and exercises that might feel too risky on land. Balance-specific training deserves particular attention in any comprehensive approach to addressing leg weakness, because weakness and balance problems are closely interconnected, and because balance training has its own distinct body of research supporting its effectiveness in reducing fall risk, a critical concern for older adults given the serious consequences that falls can produce. Tai Chi has an unusually robust body of research support for its specific benefits in balance and fall prevention among older adults, with numerous studies finding significant reductions in fall risk among people who practice it regularly. The slow, controlled movements of Tai Chi train the proprioceptive system, the body's sense of its own position in space, in ways that complement the strength benefits of resistance training and that address the balance dimension of functional leg health that pure strength training does not fully cover on its own. Simple balance exercises, including standing on one leg while holding onto a stable support for safety, can be practiced at home and gradually progressed as balance improves by reducing reliance on the support and eventually attempting the exercise without support for those who develop sufficient confidence and stability. Heel-to-toe walking, placing one foot directly in front of the other in a straight line, provides another accessible balance challenge that can be practiced along a hallway or any clear stretch of floor with a wall nearby for safety if needed. Nutrition plays a critical supporting role in any effort to address leg weakness and rebuild muscle strength, and the specific nutritional needs relevant to this goal deserve clear explanation. Protein intake is the most critical nutritional factor, given the anabolic resistance that makes older muscle less responsive to protein intake than younger muscle. Research suggests that older adults working to build or maintain muscle mass benefit from higher protein intake than general population guidelines suggest, often in the range of 1 to 1.5 grams of protein per kilogram of body weight per day, distributed across meals rather than concentrated in a single meal, because the muscle-building response to protein intake is more effectively triggered by moderate amounts spread throughout the day than by one large protein-rich meal. Practical sources of high-quality protein that are accessible and that most people can incorporate into their regular eating patterns include eggs, fish, poultry, dairy products including Greek yogurt and cottage cheese, and for those following plant-based diets, combinations of legumes, whole grains, and, if desired, plant-based protein supplements that can help ensure adequate intake. Vitamin D deserves specific mention because of its role in muscle function, and because deficiency is extremely common among older adults, particularly those with limited sun exposure, and because adequate vitamin D status has been associated in research with better muscle function and reduced fall risk. Many older adults benefit from vitamin D supplementation, though the appropriate dose should ideally be determined based on blood testing and discussion with a healthcare provider, rather than arbitrary self-supplementation. The timing of intervention matters significantly when it comes to addressing leg weakness, and this is worth emphasizing clearly because of a tendency some people have to wait until weakness has become quite significant before taking action. The earlier that resistance training and adequate nutrition are introduced into the response to developing leg weakness, the more effectively the underlying muscle loss can be addressed and the more functional capacity can be preserved or restored. This does not mean that intervention started later is not valuable. The research on resistance training in very elderly populations, including people in their 80s and 90s who have experienced significant pre-existing weakness, consistently shows meaningful improvement is possible at essentially any age and any starting point of functional capacity. But earlier intervention generally produces better and faster results, and there is genuine value in addressing the early signs of leg weakness, the slight difficulty rising from chairs, the new awareness of stairs as something requiring more effort, promptly rather than waiting for the weakness to become more pronounced and more functionally limiting. The psychological dimension of addressing leg weakness deserves acknowledgement as well, because the relationship between mental outlook and physical effort in this area is significant and well documented. Many older adults have internalized cultural messages suggesting that declining physical capacity is simply an inevitable and unmodifiable feature of aging, a belief that research on what is sometimes called self-efficacy has shown to actually influence outcomes, with people who believe that improvement is possible engaging more consistently with the activities that produce improvement and consequently experiencing better results than people who have accepted decline as inevitable and consequently engage less consistently with potentially beneficial activities. Understanding clearly, as the research genuinely supports, that leg weakness after 60 is substantially modifiable rather than simply an immutable feature of aging is itself a meaningful psychological foundation for taking the kind of consistent action that produces real results. The functional benefits of addressing leg weakness extend well beyond the legs themselves, and well beyond the measurable strength improvements that exercise testing can document. Stronger legs mean greater independence in daily activities, from the basic functions of rising from chairs and climbing stairs to the broader activities that contribute to quality of life, including the capacity to travel, to participate in social activities that involve any degree of physical engagement, and to maintain the kind of active life that most people associate with genuine well-being in their later years. Stronger legs also mean significantly reduced fall risk, which matters enormously given the serious consequences that falls can produce in this age group, including fractures that can trigger a cascade of health complications and loss of independence. And the broader metabolic and cardiovascular benefits of resistance training and physical activity provide health support that extends well beyond the legs into virtually every system of the body. What this all adds up to is a message that deserves to be communicated with real clarity and real confidence to anyone over 60 who has noticed their legs becoming weaker. This is not simply something to be endured or accepted as an unavoidable part of aging. It is a specific, well-understood biological process with specific, well-researched interventions that have been demonstrated repeatedly to produce meaningful improvement, regardless of starting point or age. The legs that have carried a person through decades of life retain, even after 60 and 70 and well beyond, a genuine capacity to respond to appropriate challenge with renewed strength and renewed function. Beginning that process through consistent resistance training, adequate protein intake, attention to balance, and a genuine belief in the body's continued capacity for positive change, is one of the most valuable investments anyone over 60 can make in the years of mobility, independence, and active living that remain ahead of them.